And then Renee, would you mind just introducing yourself as part of the ECHO team?
Not at all. Renee Bolio Banks Indigenous Cause, and Zibique Indigenous Cause Indigo. I am the elder in residence at Minobi Madiziwin. It's a Red Lake Pediatric Wellness Clinic. And I'm so glad to be back with my NACCians. Miigwech, thank you for, it's an honor to be here.
Which, Dr. Robbie?
Yes, hello. It's so good to see you too, Renee. Miigwech, and my name is Kari Robbie. I'm a family practice and addiction medicine physician. I've been here since 2011.
Good, and Nikki.
I'm Nikki Jardina. I'm a public health nurse. I'm the syndemic nursing supervisor at NACC and part of this team.
Good, and I'm Lindsay Kinkuni. I'm the harm reduction supervisor, and I also facilitate this ECHO program. So that's our team, and then I'll just do some announcements and then we'll move on to the presentation for today. I'm just going to share my screen. All right, so welcome again, everybody. This is the Midwest Tribal ECHO Opioid Use Disorder Education and Treatment Series. Today we welcome Simone Megas-Harmason, Chyna Pfeifer from NACC, and Rob Moxley-Goldsmith from Hennepin Healthcare. They are going to be talking to us about building partnerships and caring for Native American community members with OUD in jails. A little bit about NACC. We are an FQHC that was established in 2003. This is a list of all of our services that we provide at the clinic. We have our website listed at the bottom, so please feel free to go to that and you can learn more about us. This is a list of current open positions that we have currently at NACC. Again, our website is at the bottom. If you go there and go to the job section, you can read about these openings. You can always reach out to me too. I have my email address on one of the slides at the end if you have any questions. Some session guidelines, please know protected health information. If you can let me know who you are in the chat, your name, title, organization, and email if possible, I can send you information after the session. And then if you're willing and able to turn your cameras on, we love to see faces. So thank you. This is a list of other ECHOs that cover similar topics. If you want any information, my email is going to be listed here and just reach out. Some announcements. So most probably know, but we meet the first and third Wednesday of every month from noon to 1 p.m. Central Time. We are getting closer to offering CME credits again for these sessions, so I'll definitely keep you updated, but that should be coming soon. Next session is going to be December 3rd, and that will be on drug checking with Southside Harm Reduction Services. And then finally for me, case presentations, if you have any examples that you'd like to send our way, please do. They make for great discussion. And then this is a slide that has my email address. So if you need any information, feel free to reach out. And I think with that, I'm going to stop sharing. And I will hand it over to our speakers today. Thank you so much for being here.
Good afternoon. Let me try to see if I can get this going here. And I have so many open windows, if you can believe that. Let's see here. Can you see my screen yet?
Not yet. You just make sure that we have you as able to share.
Do you want me to share the slides?
Yeah, can you pull them up? I am not seeing. Hold on, maybe. Can you see them now?
Oh, there's something, yep. Just,
Yay,
think
I figured it
zoom
out.
in. If you click on the slideshow and then it should go into, yeah,
Yeah.
Yep,
yep, right there.
I had it all prepped.
Okay,
Perfect.
perfect now.
All right. Hi, I'm Simone Megas-Harmason. I work over at NACC. I am the Tribal Health Director over the NACC Red Lake programming, so the chemical health programming. I am here presenting with Rob and Chyna. Rob, did you want to introduce yourself?
Sure, yeah. Hi, everyone. My name is Rob Moxley-Goldsmith. I am the RN Clinical Coordinator of the MOUD program here at the Hennepin County Jail. I have been in correctional health for 27 years and worked in a variety of areas, and working in MOUD has by far been the most rewarding area that I've worked in, and I really can't see myself working in any other area for the rest of my nursing career. I really love it.
Thank you. How about you, Chyna?
Hi, my name's Chyna Pfeifer. I'm a peer recovery specialist, and I have been working as a peer and at NACC since 2019. Yeah.
Thank you. Get started here. So I know that we touched on just general services that are offered through NACC. We're located here in South Minneapolis. In about 2014 is when I started at NACC. Brand new, 11 years ago, almost. So I was the primary point person for screenings, brief interventions, and referrals to treatment. So a lot of care coordination services. And while doing that work, it was embedded in the medical clinic. I heard a lot of feedback from people in community, really not knowing or understanding options of care. So a lot of conversations about care, barriers, and it also gave me some perspective on understanding gaps and how to support people with navigating systems, for sure, treatment. A lot of people who are coming out of those systems, and really working with folks on figuring out how to advocate. So that really has been a huge part with sparking a lot of the work that we're doing now in the jails, is looking at those gaps and how we can support and collaborate. In 2018, NACC Red Lake created a partnered, and we have a We Know the Way, which is an intensive outpatient program, and We Do Kadadawin is our dosing clinic. Within those chemical health programs, we provide peer recovery specialists that were embedded in those programs. We also have community health workers, chemical health counselors, elder and residents, and mental health providers at that time. Our peers were program bound, I would say, at that time when we started. We looked at expanding peer services, so peers became more available within the medical clinic, along with our elders, and worked side by side with our elders in creating or in providing traditional healing services for community. And after that, we just continued to expand services, understanding that like the need for connection with hospitals was huge. So that was kind of our first step out. Outreach, obviously, we work really closely with a lot of the outreach team, but a lot of the work that we're doing in hospitals really sparked, that first step in connection to care. And we shifted into looking at how to navigate getting into jails and other areas. That was a huge part. A lot of our folks who are using substances have some touches with legal conditions, the system in general. So we started to reach out and have been open to making connections. We see incarceration is really a point of like providing some of those interventions. So that's kind of the history of where we started with our services in terms of our peers and some of our traditional healing services that we offered. I am going to move to the next slide. Did you want to touch on this, Rob?
Yeah, sure will. So here, the Hennepin County Jail is located in downtown Minneapolis. We have two different buildings that we have patients housed in. Our current census is about 760 individuals today. We tend to admit or book in about 25,000 people a year. So we're averaging 60 to 70 new people who arrive every day. And to be able to maintain that census of around 760 or so, that means that of 70 people that are admitted every 24 hours, 70 people also leave every 24 hours. So we have a lot of people kind of coming and going fairly quickly. And here at the jail, they call it pre-adjudication for people who aren't familiar with that. And so it's people who possibly have been charged, maybe not, and are awaiting court. The difference between a jail and then maybe a prison or the workhouse is for people who have been sentenced already. And so one of the challenges we have here in providing care is that we really don't know how long people are going to be here. And so when we started this program, our MOUD program in 2019, kind of our original thought was knowing that a large majority of people who are using opioids in the community do end up coming into the criminal justice system at some point. And so adding an MOUD program was really important, a good point of intervention for people. So in 2019, that was new for us. Since that time too, we've also really tried to expand here at the Hennepin County Jail overall services with really this understanding that the people who are here are not going to be here forever. This is a really great opportunity to try to provide some medical intervention for people. And so I think on the previous slide there, just kind of also mentioned that the other services that we have here. And so we have medical care 5 days a week through either internal medicine or family medicine. We have dental care on Tuesdays. We have psychiatry here. So we have APP level, so physician's assistant and nurse practitioner, 4 days a week. We have psychiatry on Fridays. And then our MOUD program here, we have 5 days a week. And because we're affiliated with HCMC, we do have access to the clinics at HCMC, specialty clinics there, and we've worked pretty hard to try to get some of those specialty clinics coming in here on a regular basis for our patients. So we do offer OB appointments here on site, and then we also have orthopedic services that come into the jail as well. So that's just a little bit of a background on the services that we provide here. I think on the next slide, so as I was saying, we have about 25,000 admissions a year. And when we started this program in 2019, we had approximately 1,700 individuals who were admitted in 2019 who self-reported opioid use when they came in. And you can see from this slide that by 2023, we had roughly 6,000 individuals who self-reported opioid use when they came in. So we've had a really steady increase in the numbers of people who were coming in and reporting opioid use. And that was really kind of in the timing with the introduction of fentanyl into the community and really higher rates of people who were self-reporting opioid use during that time. And so we tend to have about 15 to 20% of our patients here who are receiving buprenorphine or methadone. So for instance, this morning we had 156 patients who are receiving buprenorphine, and another 12 that are receiving methadone. When our program began, Elisa Woodward, who was the nurse practitioner who generally would be doing this presentation but wasn't available today, but what she was really noticing was that the rate of our patients who were coming in seemed to be much higher for individuals who identified as Native American than other demographic groups. And so we started looking at data, and from the slide you can see that Although 1% of Hennepin County's population is Native American, 8% of the individuals at the jail are, but then 24% of our patients receiving MOUD care here. And so that really prompted Elisa to start looking at how can we here at the jail increase and improve care for patients. And I think that kind of led to some discussions with Simone, and here we are today.
Thank you, Rob. So I wanted to just share some stats, post-release opioid risks in Minnesota. So this is general, right? 15.5 times that of the general population are at risk of overdose death once they leave jail or incarceration. There's an estimated rate of overdose death after prison is 28.3%. Also, if you look at the Minnesota EHR Consortium, which is a wonderful tool to look at. It really narrows stats down if you want to just get a general idea of what's going on in different areas and communities. With Hennepin County Adult Detention Facility, the annual count of opioid-involved hospital visits 90 days of release for American Indian population. Those are the stats, 15.9. as you could see in 2020, and then 2024, 14.5. So pretty steady. And that also sparked for us being present in the hospitals and having our peers present in the hospitals, looking at what other areas can we start to look at, really integrating some supports into the systems. And correction facility is a perfect place, right, to try to work on supporting people at that time when people are in a space, in a place where a lot of people feel shame, feel hopeless, feel like here I go again. A lot of people don't have their family supporting them at that point. They're caught in that cycle. And so we want to interrupt that cycle for them. Our motivation is to get peers into the jail, get peers in these systems where people can feel and understand that there is hope to make changes at times in their life when you feel like there's nothing else, right? So this is the time to, go to folks and bring care to them. I feel like treatment traditionally across the board really looks at when people are ready, they can come to us. The reality is there's a lot of folks struggling. And if we wait for people to come to us, we're going to see those numbers continue to increase. We're going to see, overdose deaths continue to increase. We are really at a place where it's time to start reaching out to our folks and creating those relationships in those spaces and places that people struggle the most. So that's part of what sparked our partnerships. There's been just gaps, right? Gaps in care. And I know Rob mentioned like some of the pieces with the jail and what you guys were seeing in the jail. And so for us, we were looking to figure out how can we get in, because jails are not easy. Jails are not easy to get into when you want to get into them. It's usually when you don't want to get into them that they want you in, right? So I don't know if you want to speak a little bit on this piece with Hennepin Health, Rob, about some of those gaps.
Yeah, I do. I think, as I mentioned, in the number of years I've worked in corrections, I can see that what has really historically been the difficulty in providing care to incarcerated individuals is getting buy-in from the sheriff's department, which takes quite a bit of work. And, the jails and just correctional facilities in general are really designed for punishment, and there sometimes is just like this lack of understanding that how people get to jail, all of the, things that led to them being here. And too often you kind of hear people say that, if if they wanted better care, if they wanted certain things, then don't choose to come to jail. And that really just shows like this lack of understanding of all of the historical traumas and reasons that people are targeted and brought to jail. And so that, of course, becomes one of our biggest challenges, which we have been grateful and thankful that we have made the inroads that we have made with the Sheriff's Department and to receive their support and understanding, which I believe took some time. I wasn't directly involved in those conversations, but really convincing them that this is necessary and needed, and patients who connect with community providers and community institutions while they are still incarcerated. There's a lot of data to show that people do better when they leave. And our hope is that as we're starting care for people here, that they're able to continue it. And so for years, there was kind of this disconnect. People come in and we get them started on medications, and maybe they have been lost to care for many reasons, and things get started and then kind of like right back out into the community with no connection to community. And so that was really important for us to try to bring in the Sheriff's Department, that understanding, and to be able to get NACC to be able to come in. Because as Simone said, when you want to have people brought in, it's really hard. There's a lot of barriers to allowing community providers to come in to a secure facility. And so I think that was probably one of the biggest challenges in the beginning. And I think that some great improvements have been made since we first started this.
And I will say, from the outside, at NACC and working, as an integrated team with our medical providers and nurses and peers, we struggle to be able to communicate at all with the jail and nurses at the jail, and figuring out, what our community members needed once they were released, so that communication and that coordination of care and continuity wasn't there at all prior to, and we're still building that relationship to try to strengthen it. But understanding like there are significant gaps, right? Because everything has been so siloed for so long. We're trying to make inroads into areas and spaces that were not always understood. So once I heard that Elise had reached out to NACC and was communicating with like specifically our MAT providers and our MAT team, I'm like, I want to meet with them. I'll go to the jail. Let's go. So that was a huge kind of cold call. So I didn't know exactly what that was going to look like, but I think it's so important to get a better understanding and just reach out and let each other know what we're doing, as a part of supporting community. And so I reached out and with Elise, and we scheduled a meeting to sit down and just have a conversation. Like, I'm not quite sure how we can support community right now from jail, bridging back out into community care, but let's have a conversation. So, we're really looking at how do we create support and goals or plans within that jail setting that once people come out, they can continue to have contact. We know that relationship building is huge, right? In Native community, for sure. Relationship building is the key to really supporting people with options of care, understanding what the need is, and listening. So having peers in the jail, being that bridge, even communicating back to community care has been important in this work so far, and we're seeing that. A big part of collaboration is sharing that vision. So as we were having these awkward conversations, not really knowing like, what can we do? What kind of work can we do together in order to like fill this gap, was sharing what your visions were. So like Elise and I had a conversation right before leaving our initial meeting, and I just said, hey, this is what I would love to see, like Chyna has been a part of that. We've all been a part of, like, how can we get into the jail? Our peers, what would, you know, if we could get in, then at least we can get an idea of what people's needs are once they leave. And I shared that vision with Elise, not really thinking that, you know, that it would go really anywhere for the most part. I figured that we would have to, on our end, continue to push to try to get into the jails and figure it out. But months later, Elise reached out and she's like, hey, we have this grant that we're looking to apply for, and we really want to partner with NACC. So a huge part of listening to each other in that collaboration and building that collaboration and really figuring out like the whys, where, you know, you're listening to patients, you're listening to other community members or people in community serving community to really get an idea of where are the barriers, how can we work together. So being very curious in that process is very important if as you're looking to serve community. And a goal of ours is to also expand the continuum of care. I think right now, especially, there's a huge piece of like people are either ready for treatment and we provide treatment, or it's just strictly harm reduction they're not ready, you know, which is fine, but there's this spectrum of care that I feel like we could do a better job of exploring in general, as providers, as people in communities, supporting those who are still using substances. And our goal is to expand that continuum of care and really figure out how can we continue to walk with people through the process as they're actively using and maybe not even thinking about treatment or recovery, or not understanding what the services are or options are, and work with folks through that process to connect to care that meets their stage of change. So that's huge for us to look at continuing to fill the gaps and walk with folks through that process and understand what community members' needs really are. As we're working with them, we have a lot of people who are unhoused, that get lost in the shuffle, get lost in the systems. And it really is our responsibility to support them. And a lot of that is, you know, implementing traditional healing care pieces into, you know, their medical care, their chemical health care. And so really helping people understand that wraparound of services and what we provide to make sure that people are taken care of holistically, and breaking down those silos is huge. So then when they see that, you know, Chyna's in the jail working with the provider in the jail, but also they see him at an outreach event, you know, when they're coming to get supplies, harm reduction supplies, that's huge. You know, that connection back to community, that familiar face, that person who was there with you as you know, are in different systems or in the hospital, you know, that person is showing up for you. And that's a huge piece of feeling safe, creating those relationships and knowing that someone is in it with you. So, you know, that takes a lot of modifying your plans as you're moving and working with people, especially when it's something new. With the jail, a lot of buy-in. We've had to work really hard on how can we introduce these services, these supports, and get the buy-in that we need in order to continue to do the work and make it sustainable. So that's been a big deal, a huge piece of trying to navigate and some of the challenges. This grant specifically offers peer specialist services. We also had an elder in residence that was going out to the jail, doing the visits at the jail. So we had to get clearance. They do one-to-one visits. For a period of time, we were offering groups within each mod, and we kind of rotated to different mods. And so we were providing some of the traditional healing teachings information, language, just anything that people really wanted to connect with, it was open. So they could connect with that elder who was in the jail in those groups. And at the same time, we also offered peers who shared resources in community, kind of made general short-term plans of what their needs were, what they felt like they needed once they were released, and tried to support with like making those connections prior to release in those group settings as well as an individual. Part of the referral process for individual visits is the medical clinic identifies those folks who are Native American, are looking to get on Suboxone. They see the medical provider meets with them. They may start them on Suboxone. I know Sublocade now is a part of that process as well, is being offered. But once they're started on the Suboxone, they get the information about peer recovery specialists, and they sign a consent and a release of information. So once the consent and the release of information are signed, they send those over to us or to Chyna as a referral. The peer recovery specialist will look and see, are they still in the jail? Have
No,
they
but
been
I can
released?
say something now.
Okay.
Simone,
Yeah.
just maybe turn your Teams off.
Oh, it's still popping up.
Yeah.
Yeah,
Holy,
it is.
I'm
I think
so
you can
sorry.
silence it if you go to Teams and then next to the chats, there's like if you hover over the ellipsis, there's a bell icon.
I am so sorry. I did not realize that. it was
No, and
still
maybe if you
on.
want to also stop sharing, we just want to make sure that there's not accidentally any MHI that comes through.
Oh my goodness.
But nothing came, it was all
It was all
anonymous. We just
yeah.
wanted to catch it before.
I am
Tracy.
so sorry. As
Oh,
you can see, I have
it's
too
hard
much
to
going on
do.
here.
It would be nice if the computers had like a do not disturb function like your phone does, like to stop all notifications.
Yeah. Max do.
Sorry, yeah,
I
I
can
know
do a
they
do not
do.
disturb. I am so sorry, you guys. I can do a do
Oh,
not
look
disturb,
at this.
correct?
Jenny Grilly at MDH is telling us you can change your status in Teams to do not disturb. Click on your little picture near the
I got
top.
it. I think
Oh,
I got it.
amazing.
I am so sorry, you guys. I did not realize that you could see that.
We're all learning together, no
Technology.
problem.
I'm too available, right?
Yeah.
All right, let me see.
Back to our regularly scheduled program.
Leave it to me. I'm like, I am not tech savvy apparently when it comes to this stuff. So I apologize. Can you see my screen?
But we can see like not your presenter view. We can see like the
There.
sidebar. Yeah.
I'm good.
There we go.
Thank you so much. I apologize for that. Okay. So referrals come from the provider. Once someone signs a consent, they also are receiving the flyer, and with the flyer, it has peer recovery bios on it. I know I'm kind of jumping around. And the phone numbers are free. So within the jail, we were able to, Elise was able to help coordinate to get those phone numbers cleared so that they are free for contact, calling out. So people from the jail are able to call out, work with a peer, kind of coordinate what next steps are. They receive the books that are here on this slide. They're able to receive books as well as a part of, they're with the chaplain and they're also with medical, I believe, at the jail. And then we've also, as a part of the grant, we're able to get Hennepin Health, part of the Hennepin Health team, use part of that grant funds to do an evaluation on the program, because that's a huge part of really understanding what's going well, what changes we need to make. So let me go to this next one. Since March of 2024, so part of the process of getting into the jail, I'm going to tell you right now, clearance has been so difficult. Like, as we have peers coming on and we had an elder that was able to get cleared, it took months. It took months to get clearance through and to be able to get into the jails. Once we were in, I feel like it's been so much easier, but as your onboarding staff, it's still that delay in being able to get into the jails and see people in a timely manner. But since March, we've had 567 referrals, which is pretty amazing from the jail. 33% of the total referrals are repeat. So what that tells us too is there's an opportunity to continue to get into those jails, continue to build those relationships, and work with people interrupting that cycle. Peers and cultural care providers, like I said, meet one-to-one. They offer groups, free phone calls. After people are released, we have a drop-in group, like a set time, and it's really just a space where people can come in, get resources. We have a NACC nurse that is also over here to support. They get care packages, so on site they can come get care packages after they're released. So their care packages are like the big military backpacks kind of, and we offer towels, weather appropriate clothing, because a lot of people who go to jail are not going, maybe release in a whole different season, right? So they need clothing, hygiene products, just general information like handbook of the streets are also in those care packages. Yes, so a lot of just general needs that people, things that people would need upon release. We are open to dropping or delivering them if they're within close range at like treatment centers. We have dropped off care packages. We put notes, cards in our care packages to let people know we're here. We want to continue to support them. We've also mailed care packages to like different treatment facilities. And our drop-in group was specifically designed so that those folks who didn't have a phone, we couldn't reach them, didn't have access, that they knew that this is a spot that they could come to on these specific times where people would be available. And those were also given out during medical appointments and put into their property. And then these are the specific flyers and information that are given out as a part of like their medical visit that I know Elise has been giving out. So some of our growing pains and challenges, a huge part of it is as we're coordinating care, releases of information signed in order to effectively coordinate care from the inside out. We have people who want to go to treatment centers, people who want to get connected to other services, and peers aren't always able to get those ROIs signed. Materials getting into the jail, that's been a very difficult when we want to bring like materials that are, you know, cultural teachings, language materials, recovery resources, anything like that. It's been really difficult to get into the jail and provide those resources. Also, just some of the barriers in terms of the work. We're bringing therapeutic work into a system that really pushes back and questions everything that we're doing. And that has caused a lot of growing pains. What we're trying to do is integrate peer and cultural services within a medical setting, within a jail setting. It's like coordinating between 3 different places has been really, really difficult as well. We're looking to continue to work on buy-in, on you know, expanding groups, expanding access to care, and bridging is a huge part of it. I also wanted to read from the evaluation that was done at Hennepin Healthcare. I wanted to read a summary that was provided from that team. They interviewed a lot of the participants within the jail who had contact with the peers. The participants, so I'm going to read this for you, described peer recovery specialists as an essential support system during the incarceration and in the transition back to community life. Having someone there from day one supporting your comeback, that's powerful. These specialists often played a dual role, offering both practical assistance, such as helping with phone calls, paperwork, and accessing services, and emotional support that helped patients feel seen, valued, and less alone. Many participants initiated contact themselves, often after seeing a flyer or hearing about the program through the word of mouth, and were met with prompt responses that contributed to a sense of being cared for. While some participants had only brief or interrupted contact, others described long-term consistent relationships with their peer specialists that extended post-release and created a strong foundation for ongoing recovery. The continuity of these relationships was particularly meaningful for participants who expressed that having someone witness both their struggles and their growth created a powerful source of grounding and accountability. Participants expressed interest in continuing with peer-led services, not just as recipients, but as potential future peer supporters themselves, emphasizing the need for more sustained and structured jail to community care models. Cultural identity played a significant role in how participants connected to recovery services. Many participants highlighted the importance of receiving support from someone who shared or understood their Native American background. If Chyna was not coming from a Native American institution or didn't have those identity ties, it wouldn't have been this strong. The cultural alignment was not necessarily a prerequisite for engagement, but was described as deepening trust, enhancing credibility, and fostering a stronger sense of belonging. For others who were still exploring or reconnecting with their heritage, the presence of culturally specific services at NACC sparked curiosity and motivation to learn more. Participants emphasized traditional teachings that framed addiction as an illness rather than a moral failing, and they reflected on the protective and healing potential of cultural practices when engaged in sobriety. At the same time, some expressed caution around blending ceremonial practices with active substance use, citing spiritual and cultural boundaries that are often respected in their communities. So that's just some of the feedback. I also wanted to tag Chyna in to share some of her perspective on services that are being offered.
Yeah, so I guess there are some of the folks that I've met with at the jail, I've already known or interacted with, like through NACC or like harm reduction events, and but some I are not familiar with NACC. So there was one person that I met with who was not familiar with NACC, but she really wanted to get into culturally specific treatment programming. The first program, she was released directly from jail to treatment program, inpatient program, which was not culturally specific. But from there, I was able to connect with her counselor and get her into NACC for Suboxone, and then get her into the outpatient program here at NACC. And yeah, continue to work with her. And through that time, like when she was at the jail, she, asked me to get messages to her family. So I was able to kind of build a little bit of a relationship with her family as well. So that was kind of nice. I can share more, but I'm not sure if we have time.
Yeah, Chyna, if you want, we have about 8 minutes.
Okay, I wasn't sure if needed time for questions at the end. There's another individual that I worked with, and she used to stop in for like harm reduction supplies and traditional medicines. And after a while, she started kind of sharing some stuff with me. I knew that she had a warrant, and it was creating barriers for her to to get into housing, and she just kind of, was always kind of looking over her shoulder. Then I saw she was referred to us from the jail. So I was able to meet with her, and she was in there for a while. So, she contacted me from the jail with a free phone call to give me updates about her case. And after a while, she was released directly to treatment. So I was able to get her, drop off a care package to her at the treatment program. When she came in, I think it was summertime. When she got out, it was wintertime. So yeah, she needed some warmer clothes. She completed that inpatient program, went to a culturally specific outpatient program, and from there got into her own place. She got a car, she has a job, and she continues to keep in contact with me, give me updates, and come in for to get sage and traditional medicines. One of the last times we met, she was reflecting on her progress, and she's like, "Isn't that cool that I used to come in here for harm reduction supplies, and now I'm coming in here for traditional medicine and sharing my recovery experience with you." So I thought that's one of my favorite stories.
I just want to add, we've also had a peer that we were able to help with, under another grant, pay for their peer recovery certification. So someone who was in jail that we connected with, was out of jail for a significant period of time, looking to get their certification, was able to complete the training, and we were able to provide that peer exam fee, cover it for her. So it was pretty amazing to watch that cycle of peers also feeling empowered to become a part of that workforce and do the work within community. So sorry, we're done. Should we open it up for questions? Do we have any time?
Yeah, we do still. Yeah, no, thank you for sharing those stories, those really important stories. And yeah, I think we have a few minutes for questions, and there were a couple in the chat. I don't know if you want to stop sharing your screen, Simone, and then we
I
can
absolutely do.
see faces. Let's see here. Just trying to. First question was, oh yeah, from Cassidy. How do you guys provide pharmacy services to your patients at NACC?
So so I think that must sounds like a clinic question. And our patients who qualify can go to Muscogee-Waukegan, which is a Fond du Lac pharmacy, and those patients need to live in Hennepin or Ramsey County and be either tribally registered or have a parent or grandparent who's tribally registered. And then as far as MOUD, we have a public health clinic where we can provide for patients who want to dose daily, we can provide Suboxone on a daily basis to those patients. And then additionally, we have a PharmD who's able to help us answer, like really get into sort of like really fine-tuning patients' medications and be a resource for patients and providers around pharmacy services. Does that answer the question?
Cassidy, are you still there?
She's given a thumbs up.
Yep,
Okay.
that makes
Thanks,
sense.
Chyna.
Oh, that's right.
Thank
She's
you.
saying no camera, so thank you.
And then there was another question from Kendra. Does anyone at NACC work with the integrated access team? And Kendra, if you're still on, feel free to jump in if you had.
Yep. I work for Adult Behavioral Health Court Services and under them in Hennepin County, under the Annette Monson is my program manager. Adesla is the program director. And we on our team are Kendra Roberg, who does a lot of jail coordination, Shannon Bodke, and Nathan, I don't know his last name, Tenzin, and Sarah Chatelli. And they all go into the jail, meet with residents to do assessments for mental health and substance use disorders, and provide sort of connection to resources and stuff for people when they are released, and bus tokens and things like that. And I just felt like it would be a good idea to connect with you with them. So if you're having trouble getting in to meet with a resident, that maybe that can be coordinated through that team, or my program manager might be able to help. I know getting access to the jail is like nearly impossible for everybody. So that's not like a problem that's specific to anybody. They just have like kind of archaic bureaucratic rules and requirements. But also I think that some of the workaround could be making connections with us with our team to try to help get people resources quickly, specifically peer support to connect with people when they're released. That particular thing, I think IAT may be in a position to really provide some support to NACC for this grant.
I would love to connect. We have had an initial meeting, but I think we're still trying to figure out like what that would look like or how that works. I have sent out information, but I would love to follow up and see how we can strengthen that connection for sure. Because we met with Annette, I believe, at one point early on. So I think now we have a little bit of a foundation that we could circle back to that too.
Great. So I guess if your email is in here, I'll just send you an email to connect you via email.
Perfect.
See if we can get that connection going.
I just wanted to jump in to be mindful of time. It is 1 o'clock. There's one more question in the chat from Judy. I've heard a lot of people sorry, my chat just went away from me.
Oh, I can read it. I've heard a lot of people are being annexed to other jails to avoid overcrowding. Can people annexed still participate in the NACC program?
I
might
can
be
answer
able
that.
to,
Go ahead,
Oh.
Jen.
I can answer that one. We try to not approve individuals who are receiving or could receive grant services to go to other facilities, because we don't want that to be a barrier for them to receive it. So generally, when we identify a patient, then we tell the sheriff's department that they need to not consider them for annexation to another facility. We want to keep them here.
Right. And I just want to say our goal in the future is to really have a footprint in the jails. And I'm hoping that the sheriff's office would be willing to meet, that our services don't go away once a grant goes away, because we want to continue to do this work and work within the jail. So I just want to put that plug out there that anybody who can help us, support us in that effort to keep peers in the jail, we appreciate it. Especially those working in the sheriff's office.
Well, thank you, everybody. I think we are at time. I just really appreciate you all for being here. Thank you, Simone and Rob and Chyna, for sharing the amazing work that you're doing. And I can definitely make sure to get you connected. For those that were on today and have further questions. Simone, is it okay if I send out the slides with your information? Okay.
Yeah,
Great.
absolutely.
Awesome. Well, miigwech, everyone, and lots of thank yous and yeah, love learning more about this. And yeah, I hope you all have a great day, and I hope you'll join us again. Our next echo is December 3rd. So thanks all.
Thank you. Take care.
Bye-bye.